Hi, I'm Ipek and I'm a senior solicitor in the medical negligence department at Burdon Kemp. Now, I deal with a range of cases and some of those have to do with sepsis. Sepsis is a devastating condition that can affect both children and adults. I'm joined here today by a very special guest who will help me explore the condition a little bit further. Ron, would you like to introduce yourself?
Sure. My name's Ron Daniels. I'm an NHS consultant in intensive care working in the West Midlands. I've been working on sepsis for the last decade now, and I'm now Chief Executive of the UK Sepsis Trust and the Global Sepsis Alliance. We have managed, as a tiny charity with the UK Sepsis Trust, to bring sepsis to national attention. So we now have regular meetings with the Secretary of State for Health, and I was fortunate enough in the New Year's Honours List this year to be awarded a British Empire Medal for the Queen, which shows how this has grown as a condition.
Absolutely. You're a doctor yourself, so out of all of the conditions that you see, why did you focus on sepsis?
So as an intensive care doctor, I'm at the extreme end of illness, and in fact sepsis is one of the most common causes of critical illness, not only in the UK, but worldwide. But that's not why I got on this journey. I got on this journey because of one man called Jem. Jem was 37 when he died in my intensive care unit. And I first met Jem toward the very end of his illness, when really there was nothing more that could be done. But it became apparent talking to Jem's family that there'd been opportunities to rescue him that hadn't been taken. I think the very moment I knew I had to do this was when I was walking down the hospital corridor, following Jem's wife Karen, knowing I was about to take her into the relatives' room to tell her that her fit, strong husband was going to die. And she was going to have to go home and tell Tom and Emily that their daddy wasn't coming home, and all from this condition they'd never heard of.
So sepsis is often referred to as the silent killer. What are some facts that you can tell us?
So we've had recent figures from the government, from the Health and Social Care Information Centre, and that suggests that in the UK now we see 150,000 cases of sepsis every year, of whom 23,000 are children. Now we estimate that sepsis is claiming 44,000 lives across the United Kingdom. That's more than breast cancer and bowel cancer and prostate cancer and road traffic accidents and HIV and AIDS put together. So I think sepsis is relatively unknown, in part because until we started the UK Sepsis Trust, there was no patient-focused body championing the condition and raising awareness. Because sepsis cuts across all medical specialities and all nursing specialities, it can affect tiny babies, it can affect the elderly, it can affect fit, healthy people in the prime of their life. It's not owned by any particular medical royal college. And therefore there's been no professional body to champion improving outcomes from sepsis. And I think that's a large part of the reason. I think a second part is there's been some confusion around the terminology. Members of the public will have heard of blood poisoning, they might have heard of septicemia. Sepsis is of course both of those things, but sepsis is the current term. Septicemia is obsolete, and blood poisoning we could look at as perhaps the lay term.
So what are some of the signs that people should look out for when they suspect sepsis?
So because sepsis can affect people of any age, and because it can arise from any infection, a pneumonia, a water infection, or even something as simple as a cut or bite of sting, what we don't have is our stiff neck and headache that we might think of in meningitis. So there's no single symptom or one or two or three symptoms that we can tell people to look for. But there are some broad themes, and I think these are best expressed in our pocket cards for people. The idea behind these cards being that if you've been to your GP or you've been to your pharmacist and you've said, look, I really feel lousy, I think I've got a bad infection, do I need antibiotics? And your GP or pharmacist has said, well, probably not, it's probably a virus, but we sometimes get it wrong, look out for some of these symptoms. So for adults, we would say, use an acronym, sepsis. So we'd say S for slurred speech or confusion or just very abnormal behaviour. E for extreme pain or shivering, pain particularly in the muscles. P for passing no urine in a day. S for severe breathlessness. And then I is an odd one. It's, I feel like I might die. A lot of people who've survived sepsis said, I just knew I was so seriously ill that if I didn't do something, I was going to die. And then S describes the skin changes. Skin in the later stages of sepsis, but this may occur at home, can become mottled or bluish or discoloured. And if anyone has had a feverish illness or feels very cold and shivery and develops these skin signs, or their behaviour starts changing, or they just know that they're very seriously ill, they need to get to healthcare very quickly. So for children, similarly, we have a card, a set of symptoms that parents can look out for. And particularly for very young children, obviously, if a parent is very worried, then they shouldn't delay, even if they don't have any of the symptoms on this card, in contacting a health professional. Because very young children, especially those under 1, but also any child under 5, has an increased risk of a serious feverish illness causing a life-threatening illness. So here's some of the symptoms to look out for, when to know that your child's ill. And some of these will be really obvious. So a child who's breathing very fast. Now, we're not asking parents to measure their child's breathing rate, but a parent will know how fast their child normally breathes. And if they're breathing very much faster than that, particularly if it's in an infant more than 2 breaths per second, then we need to get some help to that person straight away. If the child's obviously had a fit or a convulsion, I'm sure few parents would leave that child at home, but obviously that might be a sign that something's very seriously wrong. Skin colour changes, as in adults, and we all know about that rash, which is one of the symptoms on the card, the rash that doesn't fade when we press it under a glass. But again, in children, the skin could be mottled or can be bluish or can be very pale, and these signs can hint, just as the meningitis type rash or meningococcal rash can hint that something's very seriously wrong. What we commonly find and what we commonly hear from parents whose children have narrowly survived sepsis is that they were trying to describe to health professionals that their behaviour of their child had changed significantly. They just weren't themselves. They were either very floppy or listless. They weren't interested in anything. They weren't wanting to play. A baby who doesn't smile, a baby who's learned to smile and now won't smile, that's quite a serious sign. And so these behaviour changes are very important. And then lastly, place your back of your hand on your child's chest and unclothed chest, and if their chest feels very, very cold, much colder than your hand, and the temperature around the child is relatively normal, then again that should be a warning sign that something might be badly wrong. And if you notice any of these symptoms in your child, don't delay, call 999. Of
course. Now, what's upsetting to know about sepsis is that if the appropriate treatment is given, a patient can make a recovery 100%. So what are some of the things that you see as a doctor of incidents going wrong?
So you're quite right. Most of what we see where things go wrong is that people just aren't switched on to sepsis. The health professional isn't thinking sepsis. And of course, these conditions, the situation can be compounded if the carer or the parent isn't saying, I'm worried this might be sepsis. So problems can occur at every stage of the journey. We know that people commonly don't present to healthcare quickly enough, so we need to educate members of the public. When they do present, they might call their GP, they might go in to see their community pharmacist, they might call 111, they might go to a walk-in centre, they might go straight to an emergency department. And so we need to educate health professionals in all areas that sepsis needs to be on their radar. Now, a GP is probably going to see, if they're unlucky, 1 or 2 cases of sepsis a year amongst many thousands of people with feverish illness. So we're never going to vilify any health professional for failing to spot sepsis at a single encounter. But what all of these health professionals should be doing is, if they think that the person is probably well enough to go home, can be cared for in the community, if they think maybe that they need a short course of oral antibiotics or they don't need antibiotics, they should admit that sometimes we get those judgment calls wrong. We should say, well, I think you've probably got a viral infection, but we sometimes get it wrong. And take these cards, look for these symptoms. If you develop any of these, then you need to get yourself straight back to healthcare. I think a second way in which things go wrong is the system doesn't pick up. We've heard in the news recently about the tragic case of little William Mead and his mum Melissa telling how she tried to contact healthcare 13 times in a very short period. Now the system needs to learn to collate these calls and to bring them together and to actually flag up these multiple approaches to healthcare as a red flag in itself.
So to help medical professionals, the charity has created a range of toolkits. Can you tell us a little bit about those?
So we created a pathway called the Sepsis 6, which is now the standard across British hospitals and is in fact 12 other countries worldwide, because it's easy to deliver and it makes a difference. It halves the patient's risk of dying. The second problem we identified in around 2010 was that people were struggling to recognise sepsis according to the official international definitions. So we created a simplified recognition tool, Red Flag Sepsis, again designed so that the junior nurse, the junior doctor, the paramedic, the GP, who's not used to dealing with sepsis on a daily basis, can know which patients we need to initiate treatment in. And then we built them together by working with the Royal Colleges, working with NHS England, into these toolkits that describe blueprints for what excellent sepsis care looks like.
And we've discussed a little bit about how sepsis can be something that can be cured. You can make 100% recovery, but there are patients who do go on to develop long-term complications. Can you tell us a little bit about things that may occur in the future if you do have sepsis that isn't treated well?
If we delay treatment, it can be critical in determining whether the person survives or not. In the very severe cases, septic shock, which is where a person with sepsis might have a low blood pressure or other evidence that their organs aren't getting enough blood, then for every hour we delay in treating, the risk of death goes up by 8%. Now, when we're looking at a patient in the community trying to get into hospital, that 1 hour might turn into 2 hours, 3 hours, 4 hours, and if we don't take an opportunity to rescue that patient, we may in fact be sentencing this patient to not survive. In terms of long-term complications, we believe that they're more common if a patient spent a long time in intensive care. So the sicker the patient gets, and this would seem obvious, the sicker the patient gets, the more likely they are to develop a long-term complication. Now, some of these are very visible. Some patients might lose part of a limb, they might lose a digit, and that will be very obvious. There are some softer physically obvious things that people can notice, which are troubling to people but tend to recover with time. Things like nails become very brittle, teeth can become brittle, teeth can in fact fall out, and hair can fall out. And a lot of our younger people who've been through sepsis find these symptoms very distressing. But what's really harmful, because people can recover from most of the physical symptoms, is the things that people can't see. The psychological trauma. Around a fifth of survivors have post-traumatic stress disorder if they've needed treatment in intensive care. Around another fifth of survivors have long-term problems with their cognitive function, their brain function. They can't think as clearly as they used to. Their personality might change. And people find that they're very tired a lot of the time and find that they tire quickly. The upshot of this is that surviving sepsis means your relationships are stretched, your career is under threat, people often can't return to work at the level at which they previously did. And we need to be able to appropriate resources to support these people. But moreover, we need to reduce these long-term complications by preventing people getting that sick to start with.
Of course. So in an ideal world, what would you hope to see for the future of sepsis treatment?
So in an ideal world, what I'd like to see is firstly a public who are aware of sepsis, not living under constant fear of sepsis, of course, because compared with a cold, it's relatively rare, but knowing that if they have a feverish illness, which we all have, once or twice a year at least, but they just know this is different, they just know something's not right, or they notice that in a loved one, that they phone a health professional and say, I'm worried this might be sepsis. We then need health professionals to be thinking sepsis as they think heart attack or as they think stroke. It needs to be one of those things that when someone presents with symptoms that just might be sepsis, they rule out before moving on to something else. So the question they should be asking themselves is, what's the worst thing this could be?
Yeah.
We also need the system to be designed to pick up cases with sepsis and to deal with these people properly. We need systems, as I've said, to collate multiple approaches to healthcare. We need safety netting tools like these cards so that when we think someone can go back to the community, they're given the resources to know what to do if they feel very much worse. And we need commissioners to commission pathways for collaborative care so that a GP knows that just as with a heart attack or stroke, that they can pick up the phone, initiate a care pathway which might involve the ambulance service, will involve the emergency department, and everyone's mobilising resources ready for the next step in the pathway. For people who do either fall through the net or despite excellent care become critically ill and need intensive care, we need proper resourced follow-up services and proper rehabilitation services.
Of course, and you've been on TV recently. There's been a lot of media attention on sepsis, which has been wonderful. There have been some tragic stories. Actor Jason Watkins lost his daughter Maud, and you mentioned Melissa Mead. Why do you think that there's suddenly been this big focus on sepsis?
So we've been chipping away at the media for a number of years now, and what we've had in the past have been media interest in issues that we've presented to the media. So we've usually had a parliamentary report, for example, or an independent report, or a piece of research that we've packaged together with some case studies and managed to gain some media interest. The difference in recent times is that the stories have reached media attention by the people who've been affected by sepsis, by, as you said, Jason, by Melissa Mead, William Mead's mum. And that makes a huge difference, because now you've not got a doctor who's a charity boss making a pitch to the media, you've got a bereaved parent, and that's very different. And it's so powerful, and we're so grateful to Jason as our ambassador and Melissa, soon to be our ambassador, for sharing their stories with the media and really bringing this to the attention. And I think, you know, although we've met with Jeremy Hunt, the Secretary of State, in the past, I think we've got Melissa to thank for this current interest from the government and the Secretary of State.
So what are some of the ways, if someone wants to help the UK Sepsis Trust, what are some of the ways that they can do that?
So there are details about donation on our website, and you know, I would just urge, of course, we are a tiny charity. We punch above our weight. We need to establish ourselves as a national body because we need some sustainable support for these patients and sustainable improvement. So there are donation pages on our website which give multiple options. Of course, we love people to put on events because events create awareness as well. And if anyone listening would like to put on an event, one idea might be to do that on World Sepsis Day, which is September the 13th. And we have some ideas on our website about what they might do. But if people haven't got time to do that, and if people have been moved by listening to this, then something very simple they can do is to use our text giving number, which is as simple as SEPS 15, so SEPS 15, and if they text that phrase together with £5 or £10 or however much they want to give to 770, then that gives an instant donation to us.